Good evening, everyone. Thank you for joining us this evening. I am Chelsea Oliver, and I'm the Director of Marketing and Community Engagement here at the Jefferson. And looking around the room, this looks like some pretty good community engagement with some cross-generational learning we're about to embark in, yes? So thank you all for being here. I have 3 jobs this evening, which is a minimum if you are in the marketing field. So 3 jobs. First is housekeeping, second is some upcoming programs, and third is introducing our speaker. So housekeeping, if you have not done so already, please help yourself to some snacks, some water, coffee, anything along the side here. If you have any questions or need any assistance, I'll be hanging out in the back with our intern, Luke. He's new, go easy on him. If you need us, we're in the back. And then also we will have a Q&A at the end of the presentation, so please write down and hold your questions until then. And Luke and I will be around with some microphones. Please wait for one of us to get to you with a microphone so our hearing assist device friends can hear your very thoughtful question. And please form it as a question and not a lengthy statement. We all are scholars and very smart folks in this room, and we all know that. But questions help our presenter answer questions. Okay? Cool. Thanks for laughing at that terrible joke. So, coming up next, we have tomorrow's event here in this room with Dr. Rhonda Matthews at 7 p.m. And she will do our kickoff to our pop culture series with Erie's Black Wall Street, and her presentation with They Not Like Us, Kendrick Lamar, Drake, and the Commodification of a Rap Beef. If you were confused about yesterday's Super Bowl halftime performance, this might be a good one to come to and learn something, yeah? Okay. And then Thursday, we welcome you at 7 p.m. to our East Erie satellite location, so Erie Center of Arts and Technology, and we will be with Dr. Paris Becker, scholar in residence of the JES, and he will be talking about cognitive conception when men become fathers. Yeah, that'll be a good one too. So for all of our upcoming events, you can find one of these handy-dandy programs throughout the JES. If you would like to sign up for anything, please see me or Luke after tonight's program. We'll get you signed up, and everything can be found on jeserie.org. Lastly, our presenter. I would like to introduce Dr. Matthew C. Becker, and as you saw on your way in, there's a very lengthy, very prestigious, very scholarly bio on the way in, so I won't read all of that to you tonight. I assure you that everyone can read in the room. We're good? Okay. So I do want to thank our sponsor, LECOM Health, for being a partner in this lecture series as well. And please join with me in giving a warm welcome to Dr. Becker.
Thanks, everybody. Appreciate it. Thanks for the nice intro. I didn't write that bio, so we'll read it together later and see how accurate it is. I tend to wander, so I'm going to use this, I think, to help us along. So thanks for coming out tonight. I'm going to take you through 50 to 100 years worth of cardiovascular science and technology. So you have 60 minutes or so. I tried to distill it down as much as I can. So if you have questions, and I'm sure you will, feel free to ask about any of it. I can't do justice to a lot of these topics because it just really, each one could be a lecture in and of itself. But I think what I really want to talk more about tonight is a couple of different issues. So the first is basically, how is it that you're accessing your health care? Because it's changed, and it's changing. And I think it's important that as providers we understand that, but I think as patients you need to understand that too. You need to look in the mirror and see what you're doing and what aren't you doing. Because we want to make sure that you're going to get the best possible care, and that has a lot to do with accessing the correct information. And the way we access information about everything, including finances, relationships, healthcare has changed a lot in the past 5 years, much less 10 years. So I want to spend a little bit of time on top of that before we delve into some of the things that we do, innovations, some research, and everything we talk about here tonight, we do and or I do, and you're able to get right here in Erie. And I made sure that everything we talk about here is relative that way. Some disclosures, I have relationships with companies. Some of them are small, some of them are bigger. I have tried hard not to let any of that bias what I'm going to tell you tonight, but being forthright, I do have relationships. This is something that Albert Einstein said on TV a long time ago, which is every kind of peaceful cooperation among men is primarily based on mutual trust. And we've had a rough 10 years, we've had a rough 5 years recently. I think one of the things that people have really changed is their perception of authority, medicine, people who are in positions of influence, power, and trust. And, it started before COVID, but during and after COVID, it really has taken off. And so, without polarizing anything or anybody, let's just talk about facts and truth. As we have come through mostly this first COVID wave and issues, I think what happened and what we've experienced now is that there's been a change in the way people get their information, what they trust, what they think is accurate, what they think is true. Some of that has been really positive, I think, and some of it's been incredibly damaging. And so I think, unfortunately, there has been now a bit of a breach in the relationship that we as providers used to have with the public. And this is something that you don't have to take my word for it. Go ahead and look at the statistics. If you look at recent statistics, which go right up into about the COVID window, historically low faith in U.S. institutions continue. This is when you had sort of the paternal role of physicians as providers. That was sort of like, Mrs. Smith, you're going to do this, you're going to do that, and I'll see you in 6 weeks and you'll show me your progress. It was paternal is what they called it. You're going to do what I tell you, and you're going to comply. And it was not as much back and forth and talking like a team relationship. It was, this is what you're going to do, because I know. I don't want to hear about your questions at all. Over time, there was some erosion. And interestingly, you'll notice that as more literature becomes available to the populace, the lower their faith in doctors continues. Now, I don't know the answer for that. I have theories. One of them is that a lot of folks are do-it-yourselfers. That's why Home Depot's out there. That's why Lowe's does so well. That's why Walmart's so popular. Because if we can, we want to. And that's a good thing about us, I think. We want to be educated. We want to be able to do our own thing and make good decisions. How many people play with their stocks? I mean, there's a whole reason there's an online EFT market. Merrill Lynch, Charles Schwab, all the different tradings. How many of you are certified financial planners that do that? Probably not the majority, but you do. I'm not saying it's good or bad, but you do it because you enjoy it. But that's a very personal thing. It's a very important thing to your life. You're playing with your financial health, but you enjoy learning and even taking some risks on occasion. And that's okay if they work or don't. Those are your risks, your choices. And so I think you've seen that not only in the financial industry, but you've seen it in the faith in U.S. institutions, including medicine. And this was primarily looking at medicine. Now, right around here is when COVID really hit us hard. And there's actually a discrepancy because some people went one way and some people went another. And isn't that interesting? So actually your political faith has something to do with how you consume thoughts, news, how you think, obviously how you vote, probably. But it also has a lot to do with what you think about government and historical institutions and even your doctor. Not right, wrong, and different. It's just something we should know about, something we should be aware about. When we look at medical science, this is not happy. So we have seen a clear decrease in the faith that both men and women have in medical science. Now, you'll notice this is from 2020 on. That just happens to be where this data came from. I don't think it has anything to do specifically with COVID. But there's been no doubt, because there was at least a lot of confusion, a lot of people started saying, well, you don't even know what they're talking about. And that's not even getting into, well, they said eggs were good, now they're bad. They said bread was good, now it's bad. Then it was butter, and then it wasn't. Then it was margarine. They can't make up their mind. It's not so much we can't make up our mind, but a lot of times you have to understand how medical science works. And it's a very slow-moving process. And it takes a lot of different findings, publications, and then verification, which means then you're going to have an overturn of things you thought were true. And it doesn't mean we're not smart or we don't understand or we're flip-flopping. It means that as we learn more and prove and disprove things, we're able to get more verification and give you to. And that's important. So because if it's true, it should be challenged every time and come out winning every single time. So these are trends. What about age category? This is, I think, sort of interesting. If you're younger, you tend to have a lot less trust. And if you're older, you tended to have a lot more trust. But again, that all went down. And in fact, now they're clustering together. In 2024, if you're young or old, you all hate us. You all think we do a bad job, and you're looking other places. This comes from the Journal of the American Medical Association. This is very fresh data, actually. So I think what this is telling us is that patients do not consider us. And when I say us, it could be a nurse practitioner, a physical therapist, a physician's assistant, doctor, a surgeon, etc. Y'all don't believe that we necessarily always know what we're talking about or always are right. Why specifically is this the case? Well, it looks as if you get some data, this is from Health last year, they don't know me, which can be fair. They don't listen to me, that's common. They do not give me all the information. They're too financially motivated, and they do not make eye contact with me. That's the least important. I don't mind if you don't look at me as long as you're smart. If you're right, you can look at the floor, give me good advice, that's fine. So these are all things that patients say. Interestingly, nowhere in there was, I don't think they're right, or I don't think they're getting their information from adequate sources, or the sources they're quoting are accurate. These are things that are more interpersonal, which historically have always been reasons patients don't enjoy an interaction with a provider. It's also the same reason you don't like your McDonald's server, or your waitress, or your financial planner. These are all common human things that if you don't get that from somebody, you're going to be upset. Interestingly, though, you get none of this on Zoom, or Skype, or TikTok, things we all love so very much. You don't get any of that. So it can't be just this, because we love all those other sources of information, and you're not getting any of that stuff. In fact, it's less personal. You're saying here, I want more personal, more understanding, more connection, more chemistry, but you're going places that give you the complete absence of that, which is TikTok and online, internet. We'll talk about that more. What are other things? U.S. majority of adults say medical doctors care about their patients' interests all or most of the time. Mostly positive, 74%. And this is fairly, 2019, right before we saw COVID hit. Do they care about doing the best thing? Most of the time, yeah, doing a good job. Provide fair and accurate information. Man, it was 50-50 2019. So there were already signs that things weren't great before we went into the great pandemic, which really stressed everybody and everything. They're transparent about their conflicts of interest, 15%. You notice how I opened tonight. I told you I have conflicts. I try not to let them be an issue, but at least I'm going to tell you about them. Admit mistakes and take responsibility. Wow, 12%. I think as a guy, we're all just, that's not just doctors, that's just us in general. I kind of live in that 12% range. Professional misconduct isn't a big deal, thank goodness, that's good. Face serious consequences, not as common. So even in 2019, there were signs that probably there was a wavering in the trust profile. Patients like social media over doctors for health information. I don't know if that's news to you, but as I said to you earlier, well, you said the things you hated the most about us is that we're not looking at you, talking to you, making a connection, looking you in the eye, and really making sure you are seen and heard. So then you went here, which is odd. Now, I get it, and I'm teasing you a little bit, but when looking for health information, people go where? Healthcare websites, half. Social media sites, cringe, 46%. And their personal doctor, 44%, so thanks. We're last. We're last. Now, to be fair, how many times have you tried to get a doctor's appointment lately? And how did that go? When you tried to get a cardiology appointment, how'd that go? Right. So I get it. I mean, that 44% of you even got in. God bless. I don't know how you did it. Tell me later. Because the issue is, it's not, I think, just that you're not sure you're going to get the right information or that you trust it. It's that accessing healthcare has never been harder. And that's if you happen to be well insured and in an area where there are resources and don't have other reasonable problems. I mean, if you live in Wyoming, south of Casper, it's a medical desert. And there's huge rates of unemployment, uninsured. So what are they going to do? I'll tell you what they're going to do. 99%, 98%, and 3%. So it's a complicated situation. So it's not all just that you don't believe us. It's that there's some issues that are our fault too as an industry. TikTok, love it, hate it. It's here, I don't know, maybe to stay, possibly this week. So it is the problem, if you're getting information, as long as you're getting good information is the problem. And, these kids these days, with the cinnamon challenges and the ice bucket challenge, and the crazy things they do. They're like gobbling down whole buckets of cinnamon and cumin, and these are challenges they do. So the point is, this is where people are going a lot to get their information, and it's not just 20-somethings. It's actually a diverse group of folks, and it's not shocking that sexual reproductive health is way up there. Dysmorphia has a lot to do with depression, body positivity. A lot of mental health issues, nutrition, diet, men's health, physical fitness, crime. This is where people are going. And that's okay if it's mostly correct, but it's mostly not correct. And I can tell you that because we can over and over and over again show you that these are just people posting things. And the internet in general is rife with all sorts of disinformation. That's a major problem because I'm thinking you might believe it and then do things based on that information. If you just go online and read all sorts of crazy stuff about some stock and you put your 401k into it and lose it all, I mean, that's really terrible. Same thing with health decisions, and you name it. I've seen some really interesting decisions made off of, well, why do you think that's real? Anyone can just post that anywhere. And it's complicated because it has a lot to do with what we think, what we don't, what aligns with our inner voices, what resonates with our choices. And a lot of times you want to support things you already believe, and you're going to go anywhere to find that. There's a thing called cyberchondriacs. We see that a lot. It's hypochondriasis, except it's cyberchondriasis, where people go on and they say, oh my God, this mole I have in my arm is 100% cancer, and they are freaked out. We all have that friend or family member for sure. And this really fuels that kind of thing, where there's improper diagnosis, self-treatment, anxiety, delays, misinformation. So, the point is there's a lot of downside too. So don't just assume, well, what's the harm? I can go on TikTok, or I can go on Facebook or Instagram, or whatever all these places are you go. There is a possible downside to it. It's not as if it's a victim-free crime. Why do I still think that you really should try and stick with the mainstream big medicine? Well, there is an incredible process that goes on that is behind the scenes for most folks, and that's okay. It should be. You don't really necessarily need to see every little bit of this. But the way we come up with drugs and products is incredibly, incredibly difficult and rigorous. Frankly, it's way too rigorous, way too difficult. It slows us down compared to Europe, where 3 times slower to get devices and products to the market. There's good and bad to that. But my point would be, there are huge benefits to peer reviewing clinical protocols, meaning that anything and everything a company or you or I or anyone wants to do has to go through proper channels. And those are very rigorous phase 1, phase 2, phase 3 clinical trials with multiple different, in theory, unbiased bodies who are looking at it, trying to seek truth, real truth, answering the question, is this helpful or not? It takes about 10 years, if you're lucky, to have a drug get patented, formulated, go through these trials and get to the market. It's about $800 million. Now, the bad news is a lot of that is eaten up in junky kind of stuff. It could easily be more streamlined. The good news is that it is very hard to fool 10 years worth of very smart people, most of whom are unbiased and just doing a job and have no stake in whether or not this is going to be a positive or negative outcome. So the credibility of the data after it goes through this washing machine and 10 years worth of scrutiny is generally accurate. I can't think of too many examples where everyone got it wrong, it was a huge deal, and people got hurt. There's always a few. You can't predict certain things. And remember, 10 years ago, when you were studying this brand new drug, you didn't know anything about COVID. There was no such thing. And certain drugs might not have been on the market, and certain other issues that are currently in common in place today weren't there. So in a sense, things are hitting 10 years after the fact. And so you can't predict those sorts of interactions and what sorts of things might happen. So we are very, very strict, and I've been my whole career involved in these sorts of things, particularly in my training, and so it is a very rigorous process, and it is designed to make sure everyone's being honest, everyone's being checked, double-checked. No one is above rebuke or review, and in fact, it's 100% expected that the most famous person in medicine, whoever that is, in that field or spot, says this, great, where's your data? As the kids say, where's your receipts? You have to see it. No one trusts anybody. You have to figure it out. And then exactly what's going to happen is in Italy and in the Ukraine or in Poland, they're going to replicate your study. And if they can't get the same results, it's debunked. It has to be proven over and over and over again. So most of what you're going to see FDA approved or brought in by the EMEA, which is the European version of that, is probably pretty darn right. It's probably pretty accurate, despite what I think a lot of us hear and worry might be going on. And I understand why there can be that fear. This is an interesting thing that I've come across a couple of different times. You know, we work in a very pressurized environment. You know, we're working in the OR and in the cath lab where people are really sick and things are going quickly. And we don't have time to make a lot of decisions sometimes. So how you can make good decisions is really important to me and the folks I work with. And it's even harder when make a good decision and make it right now. And if you're wrong, someone's going to not make it. Or you're going to lose all your money. Or your will and trust is going to be, whatever matters to you. You know, your coin collection is going away. Or you make a bad chess move and that's it. That game's over. So there's something called the ladder of inference, which I think is really sort of interesting. I have a weird voice or sound here. And it has to do with how we make decisions. And I think that it's interesting. If you look at the bottom, a wide observable ground of objective reality, the data I select. So what do you look at? It can only be as good as wide as you make it. So if you only go to TikTok, and that's all you're going to take in for your data, okay, hopefully that was a good choice. If you only look at CNBC, or Fox, or MSNBC, or CNN, or Axios, or some, European indie news outlet, you can only process as much information as you're going to get. And so the problem is if you leave stuff out, it can't be considered in your overall digestion of data. Then you go up into meanings that you create. So basically, here's your data. Then how do you assimilate that? What do you think? What are the assumptions you make about that? By the way, you notice you're getting narrower in terms of what you're actually going to use to make your decision. Conclusions you reach. So here's what I think of all the things I looked at, what I think is probably right. Beliefs I build. So how does this apply to how I then see the world? That could be religious, it could be socioeconomic, it could be very regional, neighborhood. And then the actions I'm going to take based on my beliefs, and that's going to lead to your decision. And so I think that this is really important because you're only as good here as you start down here, meaning hopefully you're getting as a wide a variety of data as you can, putting good meaning to it, meaning you understand the data, know how to interpret it, make some assumptions applicable to your current environment, make some conclusions, and then harmonize those with the situation that you're in. And I think that matters because that's how you get good decisions when you're talking to your physician, or, okay, you're not. You're making your own healthcare decisions. So how should you make good decisions? Well, the experts will tell you they should be evidence-based, and they should be based on you and your values, the best evidence, as much as you think you've researched and found on that ladder of inference, and then the clinical expertise of the physician, and then that overlap, that Venn diagram overlap, EBM is evidence-based medicine, that's what it's supposed to mean. Let me give you an example of how that is not as basic as you think. So you are an orthopedic surgeon, which I'm not. That's why I'm going to safely use this example. And there is incredible evidence about a brand new but wildly technically challenging procedure. And I'm 15 years into my practice, and I wasn't trained on it. I kind of know, but I don't really know, and I maybe do, but I mean, have I done a million of them? No. But it is clearly the best way to go. And the patient comes in and says, I want absolutely that procedure because it is less invasive. I'm going to get home quicker. It's going to be the best thing in the world. It's my values. It's what I want to do, same day in and out. And so evidence and patient values are strongly in favor. But me, the doc, is over here when it comes to clinical expertise. I have very little. So doing that procedure in this instance is a bad idea because we aren't here. We aren't here. And so a lot of things in medicine, I can tell you, we miss it here. You know, you love it, you think it, and it fits your life, great. The evidence is there, but maybe that's over here in terms of my skill set. Or I'm crazy good at all this stuff, but you're Jehovah's Witness and there's no possible way you'll ever take blood. You'd rather die. And this is a very obviously bleeding procedure, and I'm going to for sure have to give you blood. Well, then this isn't a good decision. Or you're someone who says, look, I have emphysema, I can't be intubated, I can't go through that surgery, and so even though the evidence is there, your ability is incredible, my value says I don't want a 20% chance of getting stuck on a ventilator. So this is in flux all the time, and I think to me what it says is it goes back to the very first thing that your surrogate said. They don't talk to me, they don't look at me, they don't listen to me, they don't understand me, and they don't hear me. So I think that's why I opened this up with, it's really at the end of the day like it always was. It's just trust. You have to trust that what I'm saying is based on the closest thing to truth that I know. And that's a big trust. Do I know what I'm talking about? Am I biased? Am I not? Am I getting my information from the right place? There's a lot of trust that you're putting in us. I have to trust that I can understand where you are here. And then together we have to come up with this and how it's going to interface together. So it's a team sport, no doubt about it. And I think what we now know is that we have a long way to go to get back to where we should be in terms of doing this right. You know, we have to have trust back. We have to earn that. And then we have to be in a place where we can sit down for more than 30 seconds and understand what is it we're trying to discuss here. What are we trying to understand here? So that I get to know you and what you really want. You get to understand what the best science is, and then I get to kind of tell you, and within the best science, here's where I think I fit. Because trust me, it is not true that every single doctor is the best at the best available evidence. How could it possibly be? How could it be? If that were true, there wouldn't be Cleveland Clinic or Mayo Clinic or Helsinki or wherever else you want to go, right? There's places that are just exceedingly good. The good news is most docs are going to tell you one way or the other in how they talk with you and discuss. And most folks are going to say, you know, you might need that new hybrid something carotid procedure. I know a gal who does a great job. I'm going to refer you. Perfect. Perfect. There's good advice, good trust, respect what you want to know, and you're going to get the best care. So you're still going to get here. It just may not be with Matthew Becker or Dr. Cho or someone, but that's okay. It's okay. You still got what you were looking for. No different than Mike's Tire Shop, or your financial planner who says, you know, I'm not great at Roth IRA back ending something, but I know a guy. Tax, I don't do taxes. I do estate planning. Sure, that's why it's a big world. Okay, so on to the fun stuff. So things we do and things you should be seeing right here, right in town, all the time. This is something that's, I think, a really big deal. Renal denervation is, in a sense, a cure for high blood pressure. This is something that we broke the rack on in April last year, doing the first cases commercially available east of the Mississippi. We were one of the first in the country within a week or so. This is complicated, but let me, and I tried not to make this miserable for you, but let me kind of show you why the kidneys have a lot to do with blood pressure. When you look at the kidney, which lives in your back, behind your flanks, they are intimately important in terms of blood pressure. In fact, your kidneys control your blood pressure. Most people don't know that. They think it's your heart, your brain, your blood vessels. No, it's your kidneys. Your kidneys filter a tremendous amount of blood at any given second. A quarter of the blood the heart pumps goes into your kidneys. As you know, they are then going to make urine. But they do other really important things. They secrete hormones, chemicals, chemotropes, and other issues. These are some of the names of the drugs and the chemicals that we talk about all the time. But trust me when I tell you, the kidney says, I want your blood pressure at a certain rate. And you may say, well, I thought that's because I'm overweight or underweight or I eat salt or caffeine or whatever. Yeah, a little bit. But mostly not. Mostly your kidneys are going to do what they want to do. And so there had been a lot of research, about 12 years worth actually, where there was all sorts of experiments. How could we tell the kidney to relax, calm down, and lower the blood pressure? A lot of people came and failed. We had been involved in some of those efforts early on, and to be honest with you, I'd given up on this. I just thought, well, there's just no way that they're going to keep going, because they'd spent billions of dollars and they failed over and over. And after 3 and 4 companies failed, I just figured there's just no way. But the Medtronic company ultimately acquired a company and came up with a successful pathway. And what it did was basically say the overactivity of the sympathetic nerves, which are these yellow guys here, sitting on top of the renal artery, this is which comes in and puts blood into your kidneys. If you could nuke them, like literally microwave them, you could turn off the switch to the kidneys until the kidneys relax, stop doing the thing you're doing to make blood pressure high. So they started, and they used animals, and they did this and that. And as you can imagine, you really want to know that you're right about this, because if you turn off those nerves, and yes, they get rid of blood pressure, but they also get rid of very important things like blood synthesis products or adrenaline to make your heart rate go, you could really hurt somebody or something. So after 10 years, they came out and got successfully approved what they call the Ardian Simplicity catheter. This is an example of the kidney. That's the adrenal gland. This is one of our catheters going up, cartoon style. This little catheter goes into the renal artery right here. That's a magnified view of it. It comes out like a pig's tail, basically. And then what happens is when we get it in place, which we do using fluoroscopic cameras and all these other things, we can turn it on, and it sends ultrasound waves out to these yellow nerves, and it essentially kills them. It sort of heat shrinks those nerves. It takes us about, I'd say 35 minutes a kidney is about my average now, because there's multiple areas in this artery that you want to go and treat. And it works incredibly well. It has this effect, which is basically getting rid of the afferent nerves going in and the efferent nerves coming out, which is decreasing the clinching activity, increasing baroreceptors, increasing renal blood flow, and getting rid of sodium, which makes you pee more. So essentially what happens is, because of all that, you get a wonderful 24-hour blood pressure control effect without any downside. As far as we can tell, after 10 years and 50, 60,000 patients, and this cadre of trials from all the way back before 2009, we can't see an obvious downside to it. There's nothing left in the body. There's no stent. There's no cutting. There's no surgery. It's a minimally invasive pinhole in your groin to get up in there and do this. And so far, there's not been a safety signal at all. We've had good success. December of 23, I want to say, it got approved by the FDA. And like I said, I think April 24th of last year, we did our first cases. And we saw success very much like this, meaning that within 6 months, 15-point blood pressure drop. A lot of these people get that while they're coming off of their medications. So folks who are on 3, 4, 5 different blood pressure meds and still getting 160, 170 blood pressure readings. So really high pressure on a lot of meds. They're now down to 2 meds, and they're in the 140 range. And then as you can see, as time goes down, they're literally at 36 months in a series, 32 points lower. So 32 points lower and off many of their medications. To put this in perspective, there was a trial that was a really big deal when I was coming up called the HOPE trial, where a drug called ramipril or Altase was an ACE inhibitor, and this was like a really big deal. That drug lowered blood pressure on average 4.5 points compared to its competitor, and it was hailed as a miracle. You know, this is it. This is forevermore. We'll always be using this. And we just thought it was the most amazing thing in the world. And it was a pill, and it went to 5 millimeters mercury different. Well, here we're getting 32 with no medications. This is with a procedure that in and out. And we're really proud to be the first folks pretty much anywhere going ahead and doing this with our first 4 people. We still see them, and a couple of them work with us, and they're doing really quite well. We continue to do this. We have more and more. I think we have a couple coming up in a couple weeks. So our experience builds, and so far it's been really quite good. Biggest problem, insurance coverage. The catheter costs $16,000. It's FDA approved, so it's okay to use. That doesn't mean insurance companies have to cover it. Now, recently there was a national coverage decision issued by Centers for Medicare, CMS. Generally, once they do that, all the privates follow. And I don't want to bore you to death with how this all works, but it can be 2 years before it's generally available to folks with the usual insurances like most of us in this room have. That's a different lecture on a different night about how does that get better or get fixed. But this is generally how this works. When TAVR valves came out, it took us 2 years. Any new product will sit usually like this. So that's a limiting factor. This is the team, and these folks, all just killed themselves to make that happen. PAD, this is one of my favorite things. Peripheral arterial disease, super common. This is when arteries not the heart get narrowed. It's usually atheromatous plaque in the legs, but it could be in the renals, it can be the carotids, it can be in your gut even. And it's a major problem because when you get blockages there, number one, you can get pain in your legs, in your buttocks, and your calves. But number two, you can get wounds on your toes, your ankles. And everyone here has known someone who's lost a leg or had a non-healing wound. It's a major, major problem. Why also it's a big deal is because the things that give you peripheral arterial disease commonly give you coronary disease or cerebral disease. So heart disease, heart attack, stroke, heart failure, these are all bedfellows with the same situations. Genetics also seem to favor all this sort of thing too. It's very common, 1 in 5 folks of Hispanic and non-Hispanic white adults, 1 in 3 people identifying as black, 77% high risk of amputation. And the problem with this, and I think the awareness problem is still quite huge, is that if you have a piece of your body cut off because of peripheral arterial disease, your prognosis is worse than pancreatic cancer. So if you have diabetes and you have a wound on your toe, and it gets to the point where you have to have it cut off, your mortality is 50% in 2 years. Why? Well, usually that's because the kind of person who's got that disease manifestation has other problems, other places like heart, brain, aorta, and it's not necessarily the PAD that's going to get them. It's a sign that they're generally so unwell. So that's why we say control the blood sugar, control the high blood pressure, control the cholesterol, make sure you're on an aspirin if that's appropriate. And for sure, early identification of things like this, plaques in your body, are important because we have all sorts of great tips and tools to get in there and early intervene and prevent it. But, it still surprises me how few physicians just don't recognize. Mrs. Smith has a diabetic foot ulcer that actually is because she has blockages in her tibial arteries, and, well, we just have to take off a toe. That is extremely poor diagnosis, worse than most cancers. And so that's something that we've tried to be very open about. This is your abdominal aorta. That's about where your belly button is. These are your iliac arteries, your common femoral arteries, and then your leg arteries here. This is a replica of that when we did what we call an aortogram. So we come in through the groin for these. We take picture, that's the contrast dye, coming down, and the white narrowings you can see there are bad. That is calcific plaques like that. You can see all these major arteries going to very important organs that are majorly blocked. This person happens to have a block of the inferior mesenteric artery here. That goes to your colon. So this is someone who was having a lot of belly pain after they ate, had a lot of constipation, and it wasn't just because of their diet or something else. They had vascular angina. They weren't getting blood to their colon because there's a plaque there. That's a 99% narrowing. Here, their iliac artery going to their left leg's got an issue, here and here. So this is how we diagnose it in addition to your standard CAT scans and other types of things. Just so you know, when we say stenting, this is kind of what we're talking about. This is a stent that is crimped down. This is as it is slowly expanded by a balloon. And then you can see the stent fully expanded. One of the things I also want you to see, because it's relevant, is that is a stainless steel cage. And that actually is one stainless steel tube that has been laser cut. And it's cut with these, what we call cells. You can see they're sort of octagonal. And that is because they are a scaffold. So they go into one of these blockages like that, and then they're inflated on the balloon, and then this stent is left in place while the balloon is taken out. But that is a stainless steel piece of metal. So think of how rigid and stiff and difficult to move that is. These arteries are not straight. In fact, look at them. And everyone's a little bit different, by the way. So when we have things like this, for a long time, folks like me would say, well, geez, we're trying to go up in here and put a stent here and here. Well, what about here? And how am I going to take this piece of metal? Now, I can get it there, mostly. Sometimes you can't. But you can shove it there and inflate it. And then you've got this piece of metal like this, and the artery's trying to do that. Well, the artery doesn't like that. And then bad things end up happening. So we had some big unmet needs. Other things issue too, like for instance, that is a cholesterol plaque. And some of it's not calcified and hard. It's gooey. I mean, it's like gel. And when you hit it with a balloon, this junk can come out and shoot down the leg. It's called an embolization. That is a very difficult thing for us to cope with. It is not good news. Also, there's this kind of thing, ripping. We tear them sometimes. You know, sometimes you're ballooning arteries and they don't like it, and all of a sudden the artery gives way, and that is a very, very bad thing to see. That makes all of our hearts sink. So that's a rupture. Well, that stent right there is not blood tight. It's just a stainless steel scaffold. So that will not help you stop this bleeding. That's a big deal. 50% of your cardiac output is going into your body right through there. And then here's another issue we get into, which is called in-stent restenosis. So just like drainage pipes going out to the sewer, the roots can grow in and they can clog, and then your basement floods, like has happened to me in my Cleveland home multiple different times. Well, we can have that happen in our body too. And so that is a liability of these open cell stents. So there were a lot of things that we weren't thrilled with when it came to how we best can treat these lesions. Just so you see again, here's the balloon, here's the stent crimped down on top of the plaque. Now we've expanded it all the way. There's the plaque. A lot of guys say, well, where's the plaque go? Nowhere. We push it up into the elastic artery, and then we hold it. And hopefully it doesn't grow itself back in. So, you know, I'd worked with the Gore Company for a long time, the Gore Company meaning Gore-Tex. So coats, shoes, tennis shoes, shoelaces, from Buffalo, New York, actually, 1953. It's called EPTFE, elongated PTFE. They have a medical division that's actually very innovative. And so a while ago now, we started working on this. What can we do a better job with those specific areas? Because there just wasn't anybody looking at it. And after a lot of really not great ideas, we came up with a pretty good one. And then we did some trials on it. And that led to this, which was the Viabon balloon expandable stent. The very first trial on that was 234 devices, 100% technical success, which was pretty nice. I did not do every single one of these, by the way. That's not how it works. Internationally, this goes out to a bunch of different places so that multiple people with multiple different techniques can use it, so we can make sure it's applicable where you're at. But great results. 100% we got it to the target. We got it open and it stayed there, and 100% deployment at the target site. 234 devices were delivered in those patients, and the VBX stent got to market, and it did a great job. We brought it to St. Vincent, where I was at the time, and we started using it pretty aggressively. And to this day, we use it a lot. And I will still say, I am biased, but I still think it's the best prosthesis we have in that space. Our second generation is now out and around. It's technical why it's Gen 2, but still cool. This is an example of a case that we did. Here is the aorta. This white is that gnarly looking plaque. It comes down into the right common iliac artery. And then here on the left, you see that as well. Now, if you just put a balloon up here, you're going to crush this artery. You're going to shift this plaque. It's going to turn into a really bad day for the patient. So what we did here is what we call a kissing technique. Technically, in the medical world, we call it a CEREB technique. But we have both groins down here accessed, wires up into the aorta, and then here's the Viabon VBX stent. The black is the distal or back side of it. Here's the proximal. We line them up, and this is where your cath lab person next to you, you look at him, he looks at you, and you go, you ready? You ready? 1, 2, 3, go, and you inflate and simultaneously deploy these into the iliacs and the aorta. So you recreate the aorta and the iliac arteries, and really cool. A, super flexible. B, it's a blood-tight seal. So that means even if you perforate the artery, there's no bleeding. Also, no plaque can get mobilized and shoot downstream. So the embolization risk is very minimal. And then if the patient does this, because we like them to move, you don't have the stent causing trouble and snarling up. So really quite cool there. We had great verification a couple years ago. The 3-year data results came out. And we saw that it was still doing really well. Now, in the meantime, we figured, why stop there? One of the problems that we were having with these stents was this. This is a nickel titanium stent prosthesis. As you can see, it's an open porous structure. And the problem here, as you can see, is that ingrowth has happened, that in-stent restenosis. So the artery has grown back in on itself. There's a 99% occlusion, 80%. And then you can almost see here, too, where that stent is fracturing. And that's very, very common for nickel titanium. It's not a good alloy for considering every heartbeat and every time you move your leg for the rest of your life. So if you're 62 when the stent goes in and you're going to live till 90, that's a lot of heart cycles, 60 beats a minute, that many years. And interestingly, this part of the body is a very hostile spot because there's a lot of torsion and bending. So these stents would fracture and break. So we came up with the thought, well, why don't we just take a Viabon or Gore-Tex-laden stent, put it right through there, and reline it, just redo it, and now it's blood tight with a impenetrable barrier. And so here's an example. We took that, we ballooned it, and then we relined it with the Gore-Tex coated stent. It kind of looks like a slinky, to be honest with you. Super flexible, it's blood tight, it's impermeable, it's a 0% fracture rate because it just can't fracture. The alloy we use just doesn't have the ability to fracture, at least under normal human circumstances. And why that matters is instead of this being a very serious fem-popliteal bypass, which I'm sure Dr. Cho will talk to you about in a couple weeks, great therapy, big surgery. This person doesn't have to go through that. This is a 15-minute revascularization fix, and it should be a lifetime fix. And so we published that here actually just last year, or 2 years ago, I guess now, right? So that's an updated FDA indication for that product. We're doing a new study now with these to look and see how in contemporary practice these would fit, and then we're just saying you can compare it to anything now. Whatever you want to use, throw it up against the wall, and we'll see if we can't beat it. So that's a pretty good open label. Pulmonary embolism is a really big deal. PE, this is where blood clots, usually from the legs, go up into the lungs and result in profound shortness of breath, low blood pressure, high heart rate, and honestly, death a lot. So when you hear, so-and-so just up and died, very commonly this is what it was. Because all of your cardiac output goes through the lungs. If you get a major blood clot blocking flow there, it is a very quick way to turn out the lights. There's a lot of people involved in this. There are a lot of different reasons for it, a lot of money spent to combat it, prevent it, but then just in general treatment for it. This is an example of how this happens. This is your vein. These are valves that live in your veins. Most people don't realize, but you have one-way stopcocks in your veins. Blood comes through, opening this, and then as it tries to go back, these one-way stopcocks shut. But if that blood is of a mind to, it can form an actual clot. It's kind of like Jell-O, to be honest with you. And then that can shoot up through your main vein, your vena cava, go into your right heart, and then clog up your lungs. If that happens, here's a microscopic depiction, here's a macroscopic depiction. As you can tell, the blood can't get through there, which means it can't get oxygenated. And worse yet, it can't come back to the left side of your heart, which is what generates a blood pressure. So triple bad news. And this is an example of a clot that we caught once on echocardiogram, so a sonogram. There's a picture of a CT scan, what it looks like. Here's your pulmonary artery. There's a piece of clot sitting there. We call it a saddle because that looks like somebody saddling a horse, for those of you who like horses. And then you can see more clot there. So bad news, very bad news for these folks. Lots of different ways that you can treat this. Over the past 10 years, we've had a lot of innovation. It used to be 10, 15 years ago, they just put you on a heparin drip and go, well, hope it gets better. And then you got on Coumadin, which is like the worst drug ever. And still the clots persisted. And so for years, we kind of learned that these clots mostly don't go away. So a blood thinner only strategy just probably isn't going to work. And for that reason, you've seen us come up with a whole bunch of other different catheters, tips, tricks, and techniques to try and get in there and get rid of the clots. Some of the ones you're going to see us use a lot more now. One is an ultrasound-assisted catheter. So it's a catheter that goes in. It'll go into the clot here, sweat out TPA, clot buster medicine, and at the same time vibrate at a certain ultrasound frequency that in theory helps the clot get exposed to the TPA and melt. Lots of debates in my world as to, is that true? Does it work? Does it not? I think, yes, it does work. How much more does it work than a simple non-vibrating catheter is the fight. But probably more important than that is not, does this work? But in what patients should we be doing it? Because this device is a mechanical thrombectomy device, and it works extremely well, particularly for those big clots that most cause trouble. So this is a company we've worked with for a long time and have done a lot of different technique innovation with. This is called an Inari clot triever. This is technically the flow triever, and you can see here a pulmonary angiogram where here's our catheter. We shoot the black dye in, and these big white globs are thrombus. And that is a massive, massive clot in the right mainstem pulmonary artery. Here the blood's getting around it and getting down to fill the blood vessels. Here we are delivering the catheter over the Rosen wire. That is what those clots look like. One of the things that we learned, we meaning I, is that 10, 15 years ago, even when I was in training, we used to say, well, they're blood clots, so you can put a blood thinner on board, and they'll melt, and that's what happens. And we were wrong. And why we were wrong is because we weren't actually taking these out. You will say, how's that possible? You guys who's going to take them out? Cardiothoracic surgeon's not going to open up your lungs and pull these out. It's a very risky proposition. These people are very, very sick. We weren't pulling them out. We were putting them on a blood thinner. And many would die, and some wouldn't. And we'd see how they did and say, well, that's what happens when you get a PE. We hope we don't get a PE. It wasn't until we actually started doing some of these thrombectomy procedures in the 2011, 12, 13 range that we started getting this out, and everyone in the room would sit there and say, that's not going to melt. That's not even clot. It's like fibrous, caulk, cross-linked, gnarly rubber. So what we learned is a lot of this is not acute clot at all. It's chronic clot that had been living in your legs, finally breaking off, going down the drain, and just sticking where it sticks, which unfortunately a lot of times is right there in your lung. So what we now know, in not even 10 years knowledge now, is that most of this we got to get out, because that is going to laugh at a blood thinner. It's just not going to go away. That's news to us. For as much as we thought we knew, this is news to us. So nowadays, and there's your pulmonary angiogram, by the way, at the end, all that white stuff's gone. Here it was before, there it is on the table, there it's gone. We've learned that this is probably the right way to do it. In every case, no. There are times and places and scenarios where one is appropriate, one isn't, and this again goes back to, you got to trust us, that we know when and why and how. And based on all sorts of different clinical variables, we say, well, this is probably the right way to go after this particular issue, because there's a lot of nuance, One of the things that came of this was we had a lot of folks, because no one is unaware that there's been a very bad epidemic of fentanyl and heroin abuse and all sorts of different drugs, but fentanyl is a big one. Heroin's another big one. And the kids will get a hold of this and they inject it frequently. And, it's a terrible affliction. And imagine how really in a bad way you have to be to firstly acquire this stuff, gosh knows where, and then take needles and inject it into your own body. I mean, I was taught how to do IVs and intravenous injections, and it was hard for me. I don't know how you're learning it if you're out there. And so, it's a major problem that is not as simple as, well, kids just want to get high. No, there's a real problem. And when you interact with folks the way we have, you can see that this is it's an illness like any other, and it really needs empathy and it needs addressed, and there's got to be a lot of help in many different ways beyond the scope of this talk. But what I will tell you is a unique problem evolved, which was very young people were coming in with horrific heart infections, because when you inject into the venous system anywhere in your body, sometimes they'll use toes, between the toes, that way parents don't see it, or they'll do it somewhere odd, or their friends will do it, even the scalp or whatnot. But when you put stuff, particularly non-sterile stuff, into your blood of a vein nature, it's going to contact your tricuspid valve first. So it'll go through your liver, depending on where you inject it in your body. So if you do it in your arm here, it's going to go straight to your heart. It's not going to go to your liver first. So it's going to go straight to your heart. It's going to go through the right atrium and right to your tricuspid valve. Bacteria love the tricuspid valve. It's complicated why, but they do. It's like peanut butter and jelly. They love it. So they get on there and they have a party. And they start to colonize and they start eating the tricuspid valve. They eat it. That's how they get their nourishment. And these folks come in extremely sick, very, very sick. And they're so sick, surgeons say, cannot take them to the OR. I'll kill them. And we were having a ton of people come in, 23, 22, 25, 19, and just losing them because they're so sick with this sepsis, the antibiotics won't work. It won't break this up. The surgeons would say, it's a death sentence. I can't take them. And we'd say, well, it's a 26-year-old. We can't let them not make it. So after a bunch of this, we sort of said, what if we went and took that here device? I mean, we got pretty good at it, sucking out blood clots. We have to go through this valve anyway to get up into the pulmonary artery, and we're cardiology, we know our way around the tricuspid valve. What if we went in and sucked that off? They're too sick, fine, let us have them. And so we did the first, where we went up in and we took that device. Very, very sick 26-year-old person, her mother signed off and said, we understand that it's never ever been done, it's not anything that we know will work, and you may kill her by doing it, but if we don't, there's no doubt what's going to happen. So we went up in, here's our catheter, here's the tricuspid valve. This is a TEE probe. This is in her esophagus coming in from the top. We're angling it in her stomach, shooting up to look at the valve. So it's kind of giving us imagery. So on one hand, we're guiding on the fluoroscope. On the other hand, we have a picture here of the TEE showing us what's happening. And by doing that, we were able to, whoops, there you go, suck out the junk off the tricuspid valve. And that girl did great. She survived. She got through it. And so we published that. Subsequently, that's now FDA approved as well. Interestingly, not a thing had to change about that catheter. Not a single thing. It works just the way it was supposed to. It's just a different application than what they'd initially envisioned. But commonly, that's how these things happen. Coming up on time, blood clots in the legs. We talked a lot about that, how they occur, what they look like. This is a very common thing no matter your age. Now, as you get older, all things happen to you more. That's just life. But particularly when we got into COVID, we saw a really serious issue with blood clotting. So here's the first wild type COVID, COVID 1 as we say, Gen 1. That was gnarly, really bad. If you got it, you probably recognized it, but the clotting situation was really, really quite rough. But interestingly, Omicron hit us pretty good too. When we were dealing with it, we saw it because it wasn't in the acute right there tonight, oh, they have COVID, oh, and they also threw a blood clot. That didn't happen. It was usually a week to 3 months later, someone had beaten it. Sometimes it was a serious infection, sometimes it was trivial. We had people who barely knew they had it, and they would get massive blood clots, or they would just suddenly die. And people say, well, there you go, that's that myocarditis. No, it wasn't. It was a pulmonary embolism or it was an acute MI, heart attack, because their blood got sticky, in a sense. How does that happen? I saved you that slide, I think. Yeah, I didn't make you go through it. It's very complicated. We don't exactly know. Does COVID make your blood sticky? It sure does. Exactly what's the right way to prevent that from happening? We have ideas. We're not certain. A colleague of mine named Alex Garopoulos ran a study called Magellan where they used 10 milligrams of Xarelto for acutely ill, sick people, many of whom had COVID. And it did a great job of preventing a clot because they started it in the hospital and then you took it out to 30 days after you went home. So that seemed to be a safe, effective way to do it. But aspirin may work well, and there's some other things as well. So my point to you is that we got real good at seeing DVT and PE during COVID, more so than I think anyone really wanted to be. What do DVTs look like? Well, there's an example. This is someone who has a leg that's very red. We call this brawny induration. Do you see that, that skin appearance there? They call that peau d'orange, skin of the orange. So that is when you have venous hypertension in a leg and it starts to swell the smallest of all the capillaries. You can get varicose veins, but acutely you'll get this. That brown is rust because hemoglobin is made of iron. Iron rusts. So if it goes in your skin because it can't get out, it'll turn your skin brown. It's oxidized rust. So that's an example. Swelling, bulging veins, warm, tingling pain, sometimes just swelling. Here's a catheter we use for that sort of a thing. Here's a venogram we did on someone. That's their knee. Here is the clot, and this entire vein is now missing. You say, well, there's that. Nope, that's an accessory. This vein, that white, is all clot. Here it's going all the way up. That's the femoral head in the groin. So that's all filled with clot. Here's a depiction of what the catheter would look like. It goes up beyond the clot, and then we open this metal, we call it a coring element, and sort of straddles the vein, and then we start pulling it back like a windsock. And it will grab and somewhat macerate, tear, and trap the clot in this big, long, windsocky looking thing. I mean, it's really silly. It's not even that ingenious. And so here's an example of that. So here you were before. See, it's all missing. So that's all full of clot. There's clot. There it is after. There's no stents, no ballooning, no nothing. We just cleaned it out. And then there's that. So here, white. There's that little nubbin of a superficial femoral. There's the nubbin, and boom, boom. 15, 20 minutes a lot of times. I mean, really, actually pretty quick in and out. Not general anesthesia, it's conscious sedation, fentanyl Versed, so twilight like colonoscopy. So most people are awake. They don't have to be under. And when this person wakes up, they have one stitch in the back of their knee that is a resorbable stitch. You don't have to come back. You don't have to get pulled out. It just goes away on its own. So super minimally invasive, really, truly. There's that clot. Now, yeah, I know. Notice how much darker and richer sort of Sumatra that looks like? That's acute clot, just for your own interest. That is compared to that, which is not, and that. So that's that sort of rubber cement caulk kind of stuff. That's not acute. That is old, well-organized, rubbery kind of stuff. That is cute, dark, rich, fresh clot. And we can tell the difference when we see it. That actually might well dissolve to some extent with blood thinners. The problem is it's 50-50. Because some people will say, and that's fair, we should all be able to defend why we do things. Well, Dr. Becker, I think you're a little too aggressive. You're taking something for 100 years. I mean, people coming in, we gave them Coumadin and heparin, and they went home, and they did okay. Did they, though? Well, what do you mean? Well, 50% of people come back with post-thrombotic syndrome, where their leg looks like this. And then in a year, they get a wound here, and then it's this big, and then it's cut off. Because if you destroy the veins and the valves, these clots destroy these, and now you have venous insufficiency, and you have a non-healing wound that no one can help. I mean, no one can help. So my argument is, sure, we're not doing it on everyone, but a very extensive venous thrombosis like that, a 50-50 shot that your life is irrevocably changed is unacceptable to me. I always let people make the decision, but if we can safely, easily get in there and pull this out and send you back on your way, to me, it's a much better way. And I would say 10 years of experience doing that, it verifies that. I think we all agree. Well, I knew I couldn't do this talk without talking about coronary disease because you're supposed to be a cardiologist. Don't you talk about hearts? I do, but no one seems to find those interesting anymore. Who's got risk factors? Lots of folks. I disagree with this. I think obesity is way overstated. I think obesity is an epiphenomenon. Obesity is a sign that you frequently also have high blood pressure, dyslipidemia, metabolic syndrome, low HDL, high LDL, insulin resistance. I can go on and on about this forever. But I don't, and I can tell you, in fact, my experience is that purely being high weight for your height, as we say, or being heavier than your height suggests you should be, is not necessarily the worst thing. In fact, we call it the obesity paradox. So a lot of times we'll get someone who's quite heavy, and we'll cath them, we'll look and go, it's going to be normal, right? So there is something to that, in fact. In fact, when we look at clinical trials, it is lightweight, underweight women who do the worst for cardiovascular disease. Overweight men do the best. So I think it has something to do with those 1,500, 1,600 paintings of, the rich who were very opulent and portly, and they were red-cheeked, and it was like the sign of wealth and vibrancy. There's something to that. A healthy organism is able to sustain that weight, find the nutrients, et cetera. So I'm not huge that in and of itself is an actual risk factor. Yes, big time. Where are we? This is interesting. We were doing really well until about 2014. And then we started losing ground. So why? No one exactly knows. In theory, our technology is as good as it's ever been. Our drugs are as good as they've ever been. But we started going backwards in terms of higher morbidity, mortality for heart disease. Interestingly, I think cancer did it because we were about to go lower than cancer, and it just couldn't have it. So somehow it bought us off. But we're trying to stabilize that trend. Interestingly, last year, Americans lived less for the first time ever. So the median lifespan of a man and a woman used to be going up every year. Last year was the first year that wasn't true. It's only by, couple months on average. But nonetheless, the trend is not something we want to see. Here's a heat map, as it were. Heart disease rates, 2018 to 20. Erie, actually not bad. It's that nice little yellow, so like not bad for y'all. Real bad, deep south. We call it the stroke belt. And lots of reasons why this could be. What's a heart attack? It is when you develop a blockage in a coronary artery that feeds blood to your heart. A lot of people get confused. Wait, I thought the heart pumped blood. It does, but it is an engine. It too needs blood. And it gets it through 3 large coronary arteries. Those, if they get blocked, are going to give you one or more of these symptoms. Everyone now, I think, has heard you can't necessarily say if it's chest pain, anything can be anything. What we tell folks now in the ER who check folks in, if it's above the belt buckle, I want an EKG. Because I've seen people come in with a toothache, and it was a massive MI. Armpit burning all the time. Nausea, back pain, shoulder pain. Amy, what? We've seen it, right? I mean, it's you've seen it. It's all there. Yeah. Women, you really frequently get jaw pain, neck pain, and as we know, women sometimes experience their symptoms differently. That's been I think this is Heart Month. Red is Friday, I think, this week. But I think the news is good. So basically, if you don't feel right and something's off, come in. Just come in. Because it's not always going to be obvious. We still struggle sometimes. I mean, I've been at this professionally, paid for 15 years, and I still struggle sometimes. The difference is I can go to the cath lab and do a cath on you and go, oh, I guess I was wrong. And no harm, no foul. We know that it's okay. I don't miss in the wrong sense very often. This is, I thought, a nice way to show you. Here's a diagram of what coronary arteries look like. Notice they come off the aorta. So isn't it interesting that the heart here is beating blood up through the aorta? It's beating blood to itself. So it's sort of a metronome, like a self-perpetuating organ in a way. It's kind of interesting. No other organ I can think of actually gives itself its own life. So the heart beats its own blood to itself in a sort of never-ending cycle. Here's an angiogram showing you what these would look like on an angiogram. They're black because iodinated contrast looks that way. Here are examples of some cases we've done. Here's our catheter, the left main artery, the circumflex. Everyone can see that one, right? And there's where we put a stent in. Stenting, we talked about it, a stainless steel tube. Coronary stents these days are chromium platinum or cobalt chromium, if you care. Any engineers out there typically like that. That's thumb and forefinger. That's what they look like. So your coronaries are about the size of a spaghetti noodle, somewhere between 2 and 4 millimeters in width. Again, balloon expands, pushes plaque out. That stent then gets deployed to scaffold open the coronary artery. Here's another example. That's a widowmaker. Some folks have heard that before, proximal LAD widowmaker. That will make you very sick. So that's 90-some%. I don't know if I have an after picture or not. There's a right coronary artery. So you're looking at that going, oh man, yeah, it's really gnarly. Did you see that one? Because that's even worse. That's a bugger. That's not going to be fun. What if you didn't need a heart cath, though? You don't. So, we now have coronary CT angiograms. We just finished installing one of these over at LECOM. It's the hottest, newest, awesome deal. CAT scanner, you can go in. We have a protocol where we push a button and wham, we get a 3D image of your coronary arteries. No cath, no nothing. So we're using that starting like next week to give images like this. Why is that nice? Well, let's say tonight we're done. You've all learned all this stuff. You say, we're going to come to LECOM now because it sounds like they've really got their stuff together and this is going to be a great situation, and you get chest pain. And you go to the ER, and your EKG's okay, and your blood doesn't show any evidence of damage or anything, but you've got hypertension, maybe a little diabetes, and your mom had a heart attack at 65. We're going to hold on to you. We're not letting you go home quite yet. Well, in the old days, your options were stress test or cath. Not bad options. But what if we said, okay, we're going to put an IV in, go down the hall, and we're going to make a CAT scan of your coronary arteries. So within 2 hours of showing up in the ER, we already know you do or do not have coronary artery disease. Mr. Smith, good news. These coronaries look beautiful. Whatever you're having is clearly not your heart. We'll happily see you in a couple weeks to follow up. It might be reflux, GERD, who knows what. We don't have to worry and wait 2 days to find out it is or isn't a significant heart problem. So that's one of the great applications. People who are just well and want to know, that's actually one of the trickier groups. I have tons of people go, doc, scan me. I want to know. Okay, but what if I find an 80% blockage right there? What are we going to do? Put a stent in. Can't. Shouldn't. There's a lot of evidence that that isn't the way it works. Just putting in a stent doesn't stop heart attacks. In fact, using medical therapy might be better. So it's not as easy as that. We're not to the Star Trek area where just scan everybody, put a chip in me, and you're good to go. With these sciences and technologies, we have to understand how to apply them to you. Otherwise, we start getting in real bad problems. And I've worked in places where folks love this, and they'd rip them off left and right. And I would have no less than 15 people a week go, my CT scan said I had this, and I don't know what I'm going to do. Well, how do you feel? I feel great. Were you active? Yeah, I run 5 miles a week. Well, do you have a problem? Nope. You smoke? Nope. You diabetic? Nope. Well, don't do anything. Yeah, but what about this? There's nothing to do. It's there. We're going to watch. We're going to do other things, but it doesn't mean you need a surgery. So there's a lot of things that we have to contemplate. Here's a side-by-side comparison. For instance, this is a CT angiogram showing you calcium. Calcium has a high refractive index. When the electrons hit it, it fractalizes and it makes this white glow. Okay? When it does that, you can't see through the glow. So this person comes and we go, okay, we'll do, how am I going to tell you you're wrong? And this person's not happy. Oh, doc, well, I said 99%, 3 different lesions. I'm going to die. You got to cath me. Okay, here's their cath. So where's their blockage? Their blockage is there. Their blockage is there. This is why I say it's complicated. So a coronary artery, like all arteries, is composed of multiple layers. There's an adventitia, there's a median, there's an endothelium. When we shoot contrast, we're looking at the lumen of the tube. I can't see what's in the wall. There's calcium in the wall, but it's not affecting the actual diameter of the tube. So there's coronary artery disease, but it's non-obstructive. It's in the wall. The CAT scan can't differentiate, so it doesn't know. So that's one of the other reasons you don't just shoot a CAT scan on every single person walking around. You have to know how to employ the technology. So very commonly, do the cath, hey, Mr. Smith, you're good to go. Well, them darn radiologists lied to me, they're wrong. No, they didn't, they were right. They're looking at something different. The old anecdote about the 3 blind men feeling an elephant's leg, and one thought it was a coconut tree, and one thought it was a thing, they're all right, they're all wrong. Same deal. We're all looking at different things with different technologies, trying to see it the best we can. This is, as I close up, one of, I think, what the future holds for us. This is an outpatient ambulatory surgery center that we just finished last year. It's an $18 million standalone facility where we do all of these procedures with rare exception, including ortho and derm and pain and this and that. Why is it a big deal? Because people aren't going to hospitals anymore for their surgeries. No one wants to go to a massive hulking institution filled with very sick people who might be infected today with flu A, flu B, RSV, COVID, 1, 2, 3, 4, and who knows what. So people want outpatient, quick elective care. Our procedures lend themselves to that. We're able to do things very much quick, in and out, same day, minimally invasive, no anesthesia, or limited type things. So the statistics are out. We all know that. And so we're leaning in hard on our side to do rapid outpatient type things in the ambulatory surgery center or in the hospital outpatient department, but quicker, like using the CAT scanner or the cath lab or other innovative techniques so that you're there overnight max. Nobody wants to stay in the hospital for a long time. The insurers don't want you there, trust me. So it's in everyone's interest to get you treated quickly, safely, in and out, and that is clearly the future. If you've noticed, hospitals are going out of business. And now, there's a lot of reasons for that, and I don't pretend to understand all of it. But one of the problems is these big, monstrous 50, 80, 100-year-old facilities like Hahnemann in Philly, or Sharon down the road, or name your favorite place that ain't there anymore, is because the way hospitals get paid and get reimbursed has dramatically changed. And what they used to house in terms of illness in people has dramatically changed. And it's, a 90-year-old business plan for a contemporary business model. It doesn't fit. It doesn't fit. Those times are gone. And so, unfortunately, if you have a $400 million NYU infrastructure in New York City, you're going to have to figure out what to do with it. But you're going to have to get creative, because the old way of using pneumonia and heart surgery and broken leg and appendectomies to pay it is not going to cut it. It just won't. So if you have the luxury of not being stuck with those big old buildings and that big old model, you do this, and you lean into what the current and future of healthcare is going to be. So that's the posture that we have, and we're lucky that we're able to do that. We don't have a hulking building that we have to figure out a way to pay for. A lot more data, surgical trends, volume. And this is next week. We are opening up our brand new cardiovascular pavilion. It's a big deal. We're going to be now the third player in the region for acute cardiovascular, heart attack, stroke, comprehensive vascular care. The ambulances will start pooling into the ER February 21st, we think. And so that's a big deal for us, meaning folks who live here in Erie, because I jokingly, but not jokingly, said to you, how long does it take you to get a cardiology appointment or a derm appointment or an optho appointment? And that's if you're well. If you're sick and you need it right now, as quick as possible, there's only so many ambulances, particularly if you live in West County or in Corey or in Crawford, and there's only so many capacity centers that are going to be able to take you in. So having a third one, I think, is a very welcome thing. We're fully staffed, ready to roll. Trust me, if you get a chance to come in, the building is overbuilt. I mean, it is like a luxury hotel. It's just unbelievable. I might sleep in the ICU for a couple nights just because it's nicer than my house. So I think that, know that, and, your ambulance services and other folks are going to be aware that this is now a place that you can come for all of your acute cardiovascular needs. We're over time, sorry, but you have 15 minutes. I have no strict schedule, so if you guys have any questions or thoughts or experiences, I'm happy to answer those for you. Yes.
Thank you. You said a lot about clots. Are some clots able to resolve themselves? Those perhaps related to aphasia and TIAs? And if so, are they indicative of perhaps worse clotting problems in the future?
Yeah, so that's a good question. So the question is basically two parts. So number one is, can a clot dissolve on its own? And the answer is yes, it can. I mean, your body's actually quite brilliant. It has its own what we call fibrinolytic system, where there's always competing forces. I mean, not to get too philosophic, but there's yin and there's yang, and there's good and there's bad, and the body has this too. So in blood, there's procoagulant and anticoagulant systems. Your body's very smart at knowing if there's more clot than there should be. It can release native hormones, chemicals, peptides to dissolve it. So yes, most of the time you actually do dissolve your own clots. If there is multiple things that come together causing a problem, a very brilliant guy in the 1700s named Virchow actually diagnosed this, saying that in order for a blood clot to occur, there have to be multiple things occurring at the same time. Sticky blood, some kind of abnormality of the blood vessel, and prolonged contact. And so that's the triad we talk about. So there's usually a pathology, which you led into when you said TIA or aphasia, meaning a blood clot in the brain. So that usually means there's something more than the blood is wrong. It means there's a narrowing in your carotid artery, or there's an ulceration of your vessels, or there's some kind of an abnormal turn or kink, or maybe your blood is stickier than it should be because you got COVID, or you have a hereditary factor you were born with, of which there's many. So yes, they can and mostly do dissolve on their own. But when they don't, number one, it's a sign there's an anatomical pathology almost for sure. Number two, it also means you should obviously look to make sure that the blood isn't abnormally clotting. What you're talking about is a mini stroke, a TIA, or a defined stroke. Those are another one of those things where do not stop or think about it. Immediately ER, because the problem is, I hate to admit it, but the brain's even more sophisticated than the heart. You get about 0 to 3 hours to save the brain. The heart, we have 12 to 24, depending upon what's what. So the brain tissue is fragile. It dies quickly. Any sign or symptom of some kind of a neurovascular incident, you have to instantly get in the car and go, because every minute counts, because you only have a certain amount of time where they can give you that clot buster medicine. And, way too many times we've seen people say, oh, I sat around 2, 3, 4 hours and my arm didn't work. Finally, oh gosh, I guess I'm going to go. And they're out of the window. And now you can't get it, and it's a problem. So, yes, Yeah, they can dissolve on their own, but don't let them if you have symptoms.
Could they be indicative of worse clotting that we've seen here?
Well, they can. I mean, so for instance, if you're so again, what I like about the vascular system is it's actually very simple. I mean, it's plumbing. So a clot in an artery is going to give you symptoms. The only way you know is what artery is it. So if it's the middle cerebral artery, it's ischemic stroke symptoms. If it's the heart, it's ischemic heart symptoms. If it's the leg, it's acute limb or chronic limb-threatening ischemia. So the manifestation of the clot is going to come from the end organ. That tells us, oh, there's something wrong. Now, most of the time, we'll presume it's a clot because we understand that that's 9 times out of 10 what it's going to be. So, and I think your more broad question is, well, if there's something wrong here, can there be something wrong here? And the answer is absolutely, because it's one arterial system. What affects the brain arteries affects the heart and the legs. And so we'll always tell people, if you have heart disease, get your legs scanned. If you have a stroke, check your heart, check your legs, because it's one contained circular system. And all the risk factors that give you disease here give you disease here and here. So it's I would even say uncommon that someone has a problem in their brain and doesn't have something going on in their heart. So absolutely, that's a warning sign. Other thoughts, questions? Oh, sir.
Excuse me. Are there early detection now with blood testing, like C-reactive protein? I had a risk factor from hereditary, and one of those was the C-reactive protein. So I have not had that tested probably for over 20 years, but I have some, hereditary factors that I'm wondering, as far as preventive for future problems, whether I should have that checked again, or are there other things through blood work that could detect, really give some early detection of things like that, the blood clotting, like the C-reactive?
Yeah, it's a great question. What you're referring to is primary prevention. So this is a whole, I mean, that's another talk we should really do. So primary prevention means you don't have known atheromatous disease in your body, but you want to keep it from manifesting. There's a lot of different things that we can do. This is an area filled with misinformation, people looking to peddle you certain things. This is where people go wild with all their herbal supplements and this and that and this and that. Not to say they don't always work, but there's a lot of uncertainty about that. You're specifically quoting Paul Ritzker's work out of Hopkins, which is HSCRP. And what you're talking about is actually really fascinating. And it basically says that if you have an artery that has a narrowing in it, because what we're actually saying is this is not, it is a narrowing. But what it really is a complicated immunohistochemical problem where your endothelium, which is a cell layer, has been damaged by the infiltration of pathologic cholesterol. This is your LDL cholesterol. It has made its way into the subendothelial compartment of the artery, and your immune system has attacked it as a foreign invader. Because your immune system isn't all that smart. It just knows me, not me. If it says not me, it's going to go kill it. So monophages, macrophages, monocytes go in there and they nullify and kill this cholesterol as an invader, causing a blister. So it's not really concrete. It's a blister. And I told you all that, not just because it's fun to tell you, but also it causes inflammation. So inflammation is the basic pathophysiology in the body of trouble. And so that inflammation, particularly in the vasculature, can be detected by what you're referring to, which is highly sensitive CRP. So in an effort to be able to blood test and find out, does someone have a high risk of having that, Paul and his folks went and did those studies. And it is effective. Now, the problem is it's not the kind of efficacy you want, which is I do or I don't. I want to go to Rite Aid, buy the test, and it tells me, yes, you do or you don't. It doesn't work that way. It incrementally, along with your blood pressure, your cholesterol, your genetics, your weight, your height, all these other things can add to the likelihood you do or don't have vascular disease. So, and that's what we do. I mean, for primary prevention visits, we just sat here the other day with a 42-year-old person whose father had taken care of, and he said, hey, I don't want to end up like my dad. Let's talk about it. And we went through all these different things. And some of them were pretty basic and some were a little more erudite. And he said, well, I read on the internet, well, you can subfractionate cholesterol, the big particles, little particles, that particle, and Cleveland Clinic does it. It's got to be good. I want all that. I said, well, you can do it, but there's no evidence. He said, what do you mean? No evidence. We don't know what the big or little particles mean. Well, I thought a lot. They do. but there aren't 10-year, double-blind, randomized trials showing that management based on that particle with this statin or that drug makes any difference at all. So when you're pragmatic about it, we look at things we know make a difference, like don't smoke, control your diabetes, do be active, watch the LDL cholesterol. Yeah, statins first is a good way to go generally. We want to look at other things like your insulin resistance, your metabolic syndrome, maybe your HSCRP, maybe a coronary calcium score to look and see what the odds of you having one of those are. So there are things that we can use and risk scores we can employ to sort of round up or round down in the odds that you're going to have a problem. The problem that most people still ultimately say is, well, you just can't scan me? I mean, I just want to be scanned. We can, in a sense, I mean, assuming your insurance will let us, which they probably won't, but we could scan you, but that in and of itself introduces more trouble because, like I said, just because you have plaque doesn't mean you're in serious trouble or that we need to stent you. So it's a discussion. It gets back to that evidence-based medicine discussion. You know, where are we and where do we fall out? So 3 different people can come up with 3 different answers about what they want to do. Happy to do all of it. I tell them I'm here to help walk you down this road to keep you from making really bad decisions, but we'll come up with what makes the most sense for you. And everyone's a little different.
So there is an individualized plan possibly for everybody then. I mean, it's not one size fits all. That, for instance, you know, I've read a lot of things, you know, like intermittent fasting, watching your insulin, vitamin K, certain things that I've been reading. Maybe these are, you know, not real proven or scientific, but there may be some preventative things that can be, you know, prescribed based on more of an individualized preventive.
Yeah, I mean, well, it's tailored, and it is because everyone's different. You know, for instance, you have someone who's 72, has every sign and symptom of cardiovascular disease, and you give them an approach, and they don't want to do any of that. You know, so for them, just to take a baby aspirin a day, quit smoking, and lose 10 pounds to try and get some diabetic control is a massive step forward, and that's great. It's a huge step forward for them. And then there's people who are 33 and they run 5 marathons a year, and they're upset that their homocysteine level's 13.2 and they want it to be whatever. Okay, well, we can work on that. I mean, the goal is the goal, and it's incremental, and at the end of the day, it's what matters to you. It is independent because what works for you may not at all work for someone else. So if intermittent fasting is going to help you achieve your goal, which maybe we both agree someone is 10% over their ideal weight, and we want to reduce that because we know there's benefit separate from their blood pressure, their cholesterol, and their diabetes control. And for that person, intermittent fasting is going to get them there. Great. For someone else, it might be Ozempic. Great. For someone else, it might be carnivore diet. Fine. You know, so it's a give and a take to meet the end. And I think sometimes, even though you might use means that aren't necessarily proven, if it gets you to a proven spot, you know, benefit, then, you know, to me at least it makes sense. And I think that's where you have to just talk to your provider to understand, what are you trying to get to? If at the end of the day you get there, you know, I'm not as worried sometimes about how people get there. You know, I've told people who just can't quit smoking to try smokeless tobacco. How can a cardiologist tell someone to start chewing? Because it's better they do that than smoke 2 packs a day of Marlboro Lights, and now they're only down to 1 pack or a half a pack, or now they're off of that, and they're on Zyn, which is some chemical nicotine that the kids put in their mouths, but you know, if we're getting them off of cigarettes, if we're getting them off of a more risky behavior, then, you know, at the end of the day, you're making incremental benefit, and to everyone that's going to be different. And that's one of the, I think, the first things as a provider you have to understand. It can't be your way. That's just not the way anything works. Certainly not now. So meet people where they are, help them to try and get to where we both agree you probably should be. Because at the end of the day, it's your hard work. You know, I'm not the one out there not eating carbs and on the treadmill, and, you know, it's you. And if you don't believe what we're doing makes sense, you're probably not going to do it. So yeah, it's individual for sure. Yeah.
Yeah.
Should be
Oh,
considered.
she have-
sorry, that's okay. I can ask your question for you. What
What
factors?
factors should be considered with regard to what sort of, like Ozempic, what factors should an individual consider in taking one of those types of drugs?
So our question is basically, what else would you want to think about before you started one of what we call the GLP-1 inhibitors, Ozempic, tirzepatide, Mounjaro, these people, the drugs that I think a lot of people are talking about. So first and foremost, the drugs are incredibly effective, and the trial data is incredibly good. Now including reducing death from heart failure. Last week, the Summit trial in the New England Journal of Medicine showed tirzepatide, which is one of these mixed GLP-1, GS1 inhibitors, reduces death from heart failure. So there's evidence that reduces sleep apnea, osteoarthritis, heart attack, stroke, death, diabetes. I mean, these drugs are phenomenal. And, there's a lot of judgment surrounding them. And some people, well, it's cheating. It's taking the easy way out. Okay. That's like saying that a Z-Pak is cheating when you get a sinus infection. I mean, okay. In the old days, we just gut it out. We'd be miserable for 6 weeks and our noses would fall off, but gall darn it, we beat it the natural way. Okay. You can beat it the natural way. That's all right. The drugs work very, very well. Like any drug, there's good and bad to it. But overall, in folks that are well qualified, it is a very, very good, useful strategy to help reduce weight and then all the other things that go along with it. I think what, the root of your question is, well, singularly, is that a solution? Well, no, it's not. And everybody here, is of an age where we all know life's not that simple. It's never just easy, one bullet hypothesis. The way I see it work the best, and I prescribe a ton of Ozempic and other things like it, is it's going to supercharge the goal of weight loss. And while you're doing that, you're going to get yourself together when it comes to what is it that puts me in this situation? Is it I don't do enough activity? Is it I do a different activity? Should I do more walking, less lifting? Should I eat more protein and less carbohydrates? Do I sit around too much? Is the wintertime a bad time for me because from December until April I'm knitting and crocheting and I'm not getting up and outside because I hate the snow and everything else? What is it that is the source of my trouble? And if you can't solve that, then yeah, you're going to come off the Ozempic and you're instantly going to gain the weight back. So it's a safe, effective way to start your journey. It's, in my mind, it's sort of like a crutch. While you heal your leg, you've got this crutch to help you, and eventually, after a period of time, you're going to get to your goal or close to it, and then you're going to take yourself off, and that's when you have to really have yourself under control, where you get it. You understand the eating habits, you understand the exercise, and what that balance is, and that's different for everybody. There's some people who can eat 1,200 calories a day and gain weight. And there's some people who eat everything and they never gain weight. We hate those people. But, they're out there. So, the drug is an important one. It works really well. I tell physicians all the time, and there's some physicians, people, well, if you're going to have an attitude like that, you're going to sit here and tisk people while they have strokes, they have heart attacks, they have limb amputation. I mean, it's not my job to judge. If it's safe and it's effective, it should be something that we're making available to people so that they can have less morbidity and mortality. If you don't like it good, then you don't have to take it. But I think they're very good drugs that so far we don't see any major bad news to. I mean, there's side effects for sure. But you do have to have a game plan. You have to have a game plan like everything else that you're taking. Sir, in the back, sir.
Yeah. So if you're out in the backcountry hunting or biking or something and you get symptoms of a heart attack, is chewing a couple of aspirins, I think, which is what they always kind of recommended to do. Is that a reasonable first aid measure, or is there something maybe better, or what?
It's, first, that's a bad situation. And I do a lot of that stuff myself. So first, don't have that happen. We run an elk hunter special every August, by the way. So anybody who does that, come on by and we'll get you ready to go for the hills, because you don't want that to happen. But yes, aspirin is still incredibly useful. People poo-poo aspirin. It's extremely useful. So aspirin is salicylic acid, actually kills your platelets in your blood. It's essential for us. And that killing of the platelet makes it non-functional, and it substantially reduces the body's ability to make a blood clot, especially the kind that want to form right there. So yeah, anywhere that you're going to be, having an aspirin with you in your first aid kit makes a whole lot of sense. The problem that you get into is aspirin is almost never sufficient to stall or stop one of these events. You know, there's a very complicated interplay between the plaque and the endothelium, procoagulant factors, platelets, et cetera, that if you start having a legitimate heart attack somewhere, you got to get in. I mean, you got to get in as soon as possible to an emergency room where they have the capability of diagnosing it and then treating it. You know, even if you don't have a super fancy cath lab, using clot-busting drugs like TPA still works phenomenally well. You know, so when I got here from Cleveland Clinic in 2010, you know, we noticed that places like Warren or Corey or Bradford were having all these people having heart attacks, and we're trying to land helicopters and bad weather, good weather, and they're flying down the road, and even under the best circumstances, 5-6 hours would go by. And we said, we don't have to do this. We're going to use TPA. It's what they did in the 1990s. It worked great then. Our drugs are even better now. So we can easily just wham, give these thrombolytic drugs, which instantly get rid of the clot in the heart 99% of the time. And they work very, very well. So you don't even have to get to a super highfalutin Mayo Clinic. You can get to, you know, Telluride, Colorado, urgent care, and they mostly can diagnose you and go ahead and get you what you need. And then if you need transferred, of course, you will be. But, you know, unfortunately, if you're out there somewhere far away and you get into one of these deals, you know, it's not great. What I can tell you, though, I guess thank goodness is, most heart attacks don't kill you. I mean, even pretty big ones, they don't kill you. I mean, you do have time. You don't want to hope to have that, but I mean, if you're stuck somewhere and you have to white knuckle it, you know, most of the time, particularly with some aspirin and other basic things, you can do okay. But in no way is it, you know, oh, I'm having chest pain tonight. It's 3 a.m. I'll just take an aspirin. I'll get up in the morning and go to the hospital. That is definitely not the message. And I hope that never happens to you.
Did we have any more questions? All right, one final reminder that we do have a ton of wonderful upcoming programs, one of which Dr. Becker already alluded to with LECOM and common vascular problems. So please come on back for that one. If you need help signing up for any of these programs, Luke and I would be happy to help you. And if we could, give a round of applause to our speaker tonight. Thank you all for coming. Have a good night.